Thank you very much. So it's my pleasure to be here with you today to summarize what all our wonderful speakers had to say today on the first day of the conference proceedings. It's really nice, first of all, I will just say as a health informatician and clinician, to be with a group of people who share a collective passion for the proper use of health data in our industry to help improve both individual care and the welfare of the public in general. So we had a number of speakers today who have stated unequivocally that health data is a valuable resource that can provide deep insights that can be used for public good. I don't think there's any argument about that. Everyone seems to agree. But it's important that we acknowledge that health data, either on an individual or population basis, is an essential tool that can allow us to improve the quality of care that we provide. And so everyone seems to have acknowledged that, and it is important as I start on this that be acknowledged. The other thematic consistency is that COVID has prompted an unprecedented and frankly long overdue interest in how we organize and architect and use health data in Canada. As Nigel Hughes suggested, when you ask the question, who is promoting the reimagination of health data use in the world? Well, evidently it's a virus. It's probably not anyone in any position of leadership. It took a virus to do this. And also Gillian congratulated us on embracing, although she acknowledged it was a bit late, a data strategy, and this being the Pan-Canadian Health Data Strategy. And I would suggest that perhaps there's an advantage to be a latecomer. We can maybe leverage some of the experience and knowledge that is accrued elsewhere. Often people who lead or institutions that lead that did not necessarily start. One can think of Google, for instance. So I'm going to review, sort of go in reverse order for the speakers for the day, and start with the innovators and then talk about our international speakers, and then finish with referring to what Vivek Goel spoke about with respect to the Pan-Canadian Health Data Strategy. So with respect to the innovators, three remarkable young Canadians, and what they clearly articulated is that there are remarkable examples of innovation in the data space in Canada. There's no shortage of ideas and impetus of innovation, but they did articulate that the private and public sector, it's a difficult space to navigate. Often there has not been clear rules of engagement and cooperation, and it can be a very difficult space for innovators to work in. COVID certainly has inspired increased cooperation, but really a clear public policy framework around the use and the place of private and public sector information technologies and innovation is required in Canada, and it really should be integrated in a meaningful way rather than sort of the traditional approach of two solitudes. In terms of our international speakers, Gillian Odenkirk, Nigel Hughes, and Boji Eliasson, the first concept that came up was one of harm, and many of them referred to this. There is harm that can occur and be accrued by patients, by individuals, by populations if we do not use health data properly. And so they caution this, and that's an important thing for us to understand. Traditionally in Canada, we've considered harm largely through the lens of privacy and security of health information, but there can be physical and mental harm to individuals if we don't use their data properly. So how can we create social benefit from data and social benefit, again, individually and population-based. They explained that Canada is not unique in terms of the degree of data fragmentation that we have, but suggest that there are solutions who are ahead of us. For instance, in the European Union, more than 26 countries have joined forces to create a federated common data model. And this is called the Eden model, and suggest that that if this can be done between different nations, that there is no reason this can't be done between different provinces and territories and jurisdictions. They also suggested that the major problem, again, is one of policy and governance. It is not a technical issue, and that there needs to be a shift from analog to digital policy and governance. And there should also be a greater focus on equity. Gillian Odenkirk spoke about what is not happening in Canada. Although we do have similar levels of fragmentation, we are behind in certain ways. We are not seeing much progress on the use of coal-faced clinical data. So she suggested that our national primary care data only covers about 5% of existing primary care data. So 95% of it is not accessible for analysis or pooling to inform us. And we do not have a summary or shared clinical data set, which is evidence of why there's only 5%. There's a profound lack of clinical data harmonization, transparency, and exchange. So this is a huge issue that needs to be addressed. And the OECD countries certainly are leading. Canada certainly in this respect. There are national examples of portals and the ability for services to communicate with patients in France, in Finland, and then in other places in the world, such as South Korea, she mentioned as well, who have integrated clinical data level data in a manner that is meanwhile also protected from and is secure. So they have been able to balance security and privacy while ensuring data integration. And lastly, they talked about Canada's elephant in the room, and that is the constitutional separation of powers, saying that this, frankly, is, although it is upheld as something that we cannot overcome, and that data will be fragmented, they, as I stated before, suggest that federated models of data standardization, as demonstrated in the EU, are occurring, and there is no reason that we can't profit from these experiences, learn from them, and harmonize our health data public policy. So this sort of, for me, sets a stage, although I'm going in reverse order to Vivek Goel's statements. So given what we have learned from this, Vivek oversaw, was the lead of the Pan-Canadian Health Data Strategy, and suggested that we are at a critical moment in time, that the shortfalls for health data in Canada are substantive. We are performing towards the end of the pack in terms of our capacity to analyze COVID data. He used this as an example, but many other instances of poor data performance. And the problem fundamentally, he suggested, is our sharing of data between services and jurisdictions. We lack any trust exchange framework. This is a huge problem. So there's a bit of a legislative lacuna there. And other countries, he referred to the United States, have implemented such trusted exchange frameworks for health data, as well as examples in the European Union. So these multiple data silos, he suggested, promote cost and limit our capacity to share, ergo limit our capacity to promote social benefit. So we require, he suggests, a new health data governance, and to move beyond the analog age, and promote a digital age health data public policy and governance. And he listed 5 principal issues that need to be addressed, suggesting that this is not a technical problem. The first is there needs to be public engagement and empowerment of the citizens of Canada in this dialogue, and engagement with them on oversight bodies that drive this change. There are issues with data literacy, not only often is construed with the public, but within the health sector, with providers, as well as with leadership. And so we need to be literate about the problem we are facing and literate about the solutions. We need clear and accountable governance. And again, that ultimate accountability is to patients. We need to shift from a custodianship model to a stewardship model where there's a positive imperative to share data while protecting its privacy and security. And we need to embrace a cooperative co-design approach where there is a harmonization across federal, provincial, territorials, but also, very importantly, First Nations, Inuit, and Métis data oversight. And this should ideally be through some form of collective impact model. And ultimately, this would hopefully result in the creation of a Canadian learning health system model. So that's a summary of the day's lessons learned of the content from our wonderful group of speakers. Thank you very much. It has been a pleasure being part of this event. And as I stated at the beginning, sharing time with a group of individuals who firmly believe that we need to reimagine and rethink how we use health data in Canada for public good. Thank you very much.